Okay. Welcome to the final session of virtual seminar series on hemoglobinopathies. Today we have a renowned physician scientist, Professor David Williams from Harvard Medical School, who is going to deliver a talk on post-transcriptional silencing of BCL11A as an effective genetic treatment in sickle cell disease. Thank you so much, Professor Williams, for accepting our invitation. It is a great honor and privilege for us to have you at our seminar series. Today's session will be chaired by Dr. Anita Nadkarni. Dr. Anita is a Deputy Director and Head of Hematogenetics at National Institute of Immunohematology at Mumbai. She is a leading molecular geneticist specialized in hemoglobinopathies. Dr. Anita, please.
Thanks, Dr. Shiva, for giving me this opportunity to chair today's session. And I want to congratulate you and your team for arranging such an excellent series on hemoglobinopathies. As you know, hemoglobinopathies is a major health problem in India. And there was an immense need of such a brainstorming session for basic scientists and the treating clinicians. So today we have an eminent speaker, Professor David Williams, who has done a pioneer work in the field of gene therapy. Basically, he is Leland Fikes Professor of Pediatrics at Harvard Medical. Dr. Williams is, am I audible?
Yes, go ahead. Yes.
Okay. Because I thought some internal.
Yes.
Okay, fine. Sorry, I'll start it again. He is a professor of pediatrics at Harvard Medical School and chief of hematology oncology at Boston Children's Hospital. Dr. Williams is a graduate of Indiana State University and Indiana University of School of Medicine. After training in pediatrics at Cincinnati Children's Hospital, Dr. Williams completed fellowship training in pediatrics hematology, oncology, and University. He then became a faculty member at Harvard Medical School and of the Howard Hughes Medical Institute. Research in Williams' labs mainly focuses on understanding the interaction of hematopoietic stem cells with the bone marrow and abnormality of this interaction, which are associated with leukemia. These basic studies contribute to the translational research that utilizes hematopoietic stem cell as target for gene therapy manipulation. Dr. Williams has won numerous prestigious awards for his research, including American Society of Gene and Cell Therapies Outstanding Achievement Award for his work in gene therapy in 2012. Dr. Williams was a Howard Hughes Medical Institute investigator for more than 16 years. He is a member of National Academy of Sciences Institute of Medicine and is a fellow of American Association of the Advancement of Science. Today, he will be delivering a talk on post-transcriptional silencing of BCL11A as an effective genetic treatment in sickle cell anemia. Over to you, sir.
Well, thank you very much, Anita, Professor, and thanks for inviting me for this talk. I'm thrilled to be here, and it sounds as if this series has been really outstanding, and so we'll try to build on what you've already heard from the previous speakers and tell you about an approach that we've taken that utilizes the basic observations, including those of Stu Orkin and Vijay Sankaran on BCL11A's importance in repressing fetal hemoglobin. So let me share my slides with you. And okay, hopefully everyone can see my slides.
Yes, sir. We could see your slides. Yes.
Okay, great. So here are my disclosures, and I'll just, because there's so many of them here, I'll just point out the one that are relevant here. So we had some funding from Bluebird Bio for research in hemoglobinopathies, and we've licensed certain IP related to the talk, I'm going to give you to Bluebird. So there's some potential for future royalty streams if what I've show you, if it ever becomes a drug. And for the talk I'm going to give today, Bluebird actually manufactured the vector in a GMP facility of theirs and provided that to us for this trial. So what I want you to understand at the end is the developmental pattern of hemoglobin production. Stu, I'm sure, has already talked about that. Understand the relationship between fetal hemoglobin and sickle cell disease clinical phenotype, and then understand the importance of a particular protein that, again, I'm sure Stu talked about, BCL11A and hemoglobin switching. So as you know from your series now, sickle cell disease is due to a single base pair mutation that affects the hemoglobin tetramer, whose function is shown here, carrying oxygen and releasing it to tissues. And this mutation exposes a hydrophobic region in the beta subunit of hemoglobin. And this, in a deoxygenated state, leads to the formation of these fibrils that crystallize into a fiber and cause the misshape of the cells that characteristically gives the disease its name. And the other important part about this is that this abnormality of hemoglobin reduces significantly the capacity of hemoglobin to carry oxygen. So the phenotype is due in large part to this rigid cells that can't transverse microvasculature, and also the inability of these cells to carry enough oxygen to the tissues. So the clinical manifestations you're very much aware of, I'm sure, is chronic hemolytic anemia. And for many patients, the most severe phenotype is this recurrent pain and the acute and chronic changes that are then mediated by microvasculature obstruction. So end organ damage leading to stroke, lung disease, hypertension, renal disease, avascular necrosis of long bones, and stasis ulcers. Now, you are, I'm sure, very much aware that the likelihood is that the hemoglobin S allele in a carrier state protects against malaria. And so if you map the frequency of the hemoglobin S allele across the world and you compare that with the malaria indemnity, you'll see that they overlap. And so this is likely the reason why the hemoglobin S allele is maintained in the population. I would also point out that in the homozygous state, however, there is an enhanced risk of death in early ages from malaria. And this is something that's important, particularly in sub-Saharan Africa, probably to some extent also in your country. This is what's called a cartogram, and it maps the frequency of individuals with sickle cell disease across the world. And this is what that frequency looks like in 2010. And this is what it's proposed to look like in 2050. And you can see here by the change in the darkness of this red in both India and in sub-Saharan Africa, that there's projected to be some increase in the frequency. And this is probably related to the fact that increasingly in Africa, with the advent of penicillin prophylaxis, that children are living out of the early childhood age into the adult age. So this increase in burden on healthcare is going to be quite substantial. In the United States, this is one of the most common genetic disorders that we care for, with about 1,000 births per year. And there's estimated to be about 100,000 individuals in the United States with sickle cell disease. And this represents a huge burden on our healthcare system, with an estimated $3 billion a year used to care for individuals with sickle cell disease. And in spite of this kind of expenditure, as I'll show you in a minute, there still maintains shortened lifespan that's due to chronic end organ damage. So this is shown better here in this slide, where on the x-axis is age, and on the y-axis is the percent of death. And this is comparing sort of the 1970s with the 2000s. And you can see one thing that's clear is that there's a significant drop in early deaths. And this is really due to the universal use of penicillin prophylaxis in the United States. And you can see that there's a small increase in adult survival, shown here. And this is due to improved supportive care. But in fact, you can see, if you look carefully, that the life expectancy today of individuals in the United States with sickle cell disease is in the mid-40s, so around 45 years of age. And that's really several decades less than the life expectancy of individuals without sickle cell disease. So in spite of everything that we do, there's still end organ damage that accrues during the lifetime of an individual, and that affects their lifespan. So you've already heard in this lecture series about the genetic therapies for sickle cell disease that are being developed. And these are classified here into several categories. So one, you heard from Mark Walters, I'm sure, about transgenic expression of either the gamma globin itself or a mutated beta globin that's mutated in a way that mimics the gamma globin sequence and therefore is resistant to sickling. What I'll talk about today is transgenic knockdown of BCL11A, which is a repressor of gamma fetal globin expression. And in the future and currently in trials is gene and base editing, where either there's a removal of erythroid-specific enhancer of this gene called BCL11A to induce fetal hemoglobin, or generation of a hereditary persistence of fetal hemoglobin mutation at the gamma locus, or in the future with base editing, actual mutation repair. And these are all in various stages of development and in various stages of being implemented into human clinical trials. So why all the fuss about fetal hemoglobin? Why is that a focus for us? This is an original paper from 1948 by Janet Watson, who made the interesting observation that in babies born of mothers with sickle cell disease, and the babies had sickle cell disease, that she noticed a marked difference in the number of irreversibly sickled cells on a blood smear compared to the mothers. You can see the percentages here. Now we know that irreversibly sickled cells on a blood smear doesn't necessarily predict a phenotype, but this was the first indication that fetal hemoglobin may have a relationship with the sickling seen in red cells. So what about fetal hemoglobin in its developmental pattern? I'm sure you've seen something like this before. So on the x-axis is time, prenatal and post-birth. And on the y-axis is the type of hemoglobin that we make. And up on top is the anatomic location of hematopoiesis. And you can see in utero, while you make from the very early time the same alpha subunit, you make in the uterus gamma globin, which is a component of fetal hemoglobin. And then after birth, you shut this expression off, your bone marrow does, and you now induce the adult beta globin locus. And the relevance of this is that I, as a pediatric hematologist in the clinic, see babies all the time who early in their life have no symptoms because they have very high fetal hemoglobin. Whereas once this switch occurs, they develop symptoms because once this switch occurs, the locus that's being expressed is the beta sickle locus rather than the adult beta locus. So there's a number of studies that over time has told us that fetal hemoglobin attenuates the severity of sickle cell disease. So here are 3 studies. looking at different aspects of the phenotype of sickle cell disease: pain, acute chest syndrome, and actual survival, death. And you can see in each case, when the amount of fetal hemoglobin is high, there's an attenuation of pain, of the number of acute chest episodes. And in fact, Platt showed in a classic paper published in 1994 that if you simply ask the survival of individuals with a higher F, 9% versus less than 9%, there's a decade difference in the survival. So all of these studies told us that the level of fetal hemoglobin in a patient with sickle cell disease actually has a significant effect on the disease phenotype. The other part that's often not talked about is that fetal hemoglobin is a very effective hemoglobin to prevent sickle hemoglobin polymer formation. So this is an old study from the NIH group. And on the x-axis here is the percent oxygen concentration or saturation, with less oxygen saturation to the left. And on the y-axis is polymer formation. And what I want to point out to you here is that if you're a sickle cell carrier, this is the shape of your polymer formation. And if you're an individual who's co-inherited a sickle mutation, and on the other allele, it's a hereditary persistence of fetal hemoglobin mutation, so that on that allele, you only make gamma fetal hemoglobin. This is the shape of your polymer formation. And what's interesting about that is both of these individuals essentially are asymptomatic. But what's really remarkable is that in this person's sickle hemoglobin red cells, there's 41% sickle hemoglobin, whereas in this individual, there's 63% sickle hemoglobin, and yet there's asymptomatic. And this difference tells you how much better fetal hemoglobin is at preventing polymer formation than actual normal hemoglobin A. So this is an important characteristic of the approach that we're taking advantage of. So fetal hemoglobin ameliorates the sickle cell phenotype, as I've just shown you with HPFH. There's also specific high F populations in Saudi Arabia, and I believe also in India. And also we know from people who take hydroxyurea, which induces hemoglobin F, that these things all make the severity of sickle cell less. And one of the important things to realize is it's not helpful to have just a few cells with high F. You need lots of cells with high F to help attenuate the phenotype. So in this review by George Buchanan, he estimates, and the data aren't all that robust, but he estimates that you need above about 10 picograms of fetal hemoglobin in lots of cells to attenuate the disease phenotype. And I'll come back to this in a moment, but this means that about a third of the hemoglobin in a particular red cell is F versus sickle. So as you know, hydroxyurea is now used fairly consistently across the world to treat patients with sickle cell disease. And that's based on several studies shown here. So the first demethylating agent that was tested was actually 5-azacitidine by DeSimone and later by Tim Lay in humans, DeSimone in non-human primates. And then hydroxyurea was used by folks here in Boston, including David Nathan and Ledfin in simians and non-human primates, and Ora Platt and David Nathan in humans. So this is a figure from Ora Platt's paper in the JCI. And you can see in two different patients, it's not a very good reproduction from the paper, but you can still tell that every time the patient got a course of hydroxyurea, their F cells went up, their hemoglobin F went up, the number of nucleated reds is an indication of the stress on the hemolysis stress went down, and their hemoglobin went up. And so in each of these cases, these data suggested that hydroxyurea was driving F expression in these patients. And this led to a phase 3 study, a randomized phase 3 study by Sam Suresh that led to the FDA approval of hydroxyurea. And I'll just point out here, this is months of treatment versus the cumulative rate of events, which is VOE events. And you can see compared to placebo, there's a significant drop, but there's still events occurring. And so this isn't hydroxyurea, as many of you know who are clinicians, doesn't eliminate in everyone the appearance of VOEs. So let's talk for a minute about the switch at the molecular level. This is the beta globin, adult beta globin locus on chromosome 11. And down here is adult beta globin where the sickle mutation occurs. And you can see that the expression during embryonic development actually follows in a linear way the arrangement of the genes on the chromosome. So in utero, you express first embryonic beta globin locus, and then you turn on fetal globin locus. There's 2 genes. There's actually then 4 alleles in humans, G gamma and A gamma. And then after the switch occurs, you're primarily expressing adult beta globin. And this is regulated in part by these enhancer regions called locus control regions. These are DNA's hypersensitive sites numbered 1 through 5. And these are important in regulating the expression of the downstream genes. So it was quite unexpected that when genome-wide association studies were done to ask the question, what genes affect fetal hemoglobin levels in adults, that BCL11A, as you can see here in this Manhattan plot, came out of these studies. So these were studies done referenced below. And so obviously the beta globin locus itself is included. MIB is included because MIB regulates erythroid cell development, and BCL11A was unexpected. So this is a B cell transcription factor where there was no indication that it had anything to do with the fetal hemoglobin switch. So then Vijay Sankaran, who was a med student, a PhD student in Stu Orkin's lab when he was in his training, then went on to ask the question, what's the regulation of BCL11A during development? And you can see here that, that during fetal development and then after birth, the expression of this protein increases a significant amount. And he went on to show in this paper that if you knock down with an shRNA BCL11A expression, you have then a large increase in the expression of gamma globin shown here in this graph. And then Sing Shu in Stu's lab went on to then use this observation to ask the question, how relevant is this for the sickle phenotype? So he crossed a sickle mouse model into a BCL11A knockout. And you can see here in the middle panel, the sickle mouse model has plenty of sickle cells, small hypochromic cells with target cells, the typical sickle cell smear. But once you get rid of BCL11A and you induce fetal hemoglobin, this morphology all goes away. And in this paper, they showed this also affects for instance, the kidney function of these animals. And so there's a correction of the phenotype in the mouse model. So this sort of shows you then our thought about how to approach this basic data. Here's what happens after birth. These locus control regions are interacting enhancers with the fetal locus here. And then after birth, they interact with the adult locus, which in sickle cell patients is the sickle beta gene. And so our hypothesis is this was a really terrific therapeutic goal so that we could reverse this switch we call it flipping the switch. And in doing so, you simultaneously increase fetal globin expression and concurrently reduce expression of the sickle locus itself. And this is done coordinately, and it takes advantage of the fact also that fetal hemoglobin is a terrific preventer of polymer formation. So we wanted to rapidly translate this basic discovery into treatment. And so our approach, which is different than other approaches that have been taken in the gene therapy area, was to actually develop a vector that knocked down by RNAi BCL11A. That would then lead to downregulating the defective sickling chain and coordinately increase fetal hemoglobin and keep the alpha and beta chains in balance so that we didn't inadvertently create a thalassemia-like phenotype. And so we began this work several years ago. You can see here, this is work done by a postdoc in my lab. What we did to begin with is to use a typical vector that expressed a shRNA for BCL11A from a very strong internal ubiquitously expressing promoter called FFV. And we tested this among a large number, about 60 shRNAs to find the best one. And one of the ways we did this then was to take human CD34 cells from the bone marrow, put the viruses into them, and differentiate them into red blood cells in the laboratory, flow sort those cells that have the knockdown, and then ask the question, does this effectively induce gamma globin expression in fetal hemoglobin? So here you can see this original data. Here are 6 different shRNAs targeting different parts of the BCL11A. The comparators here are non-transduced GFP only vector and a non-targeting shRNA. And you can see in blue induction at the mRNA level and in red induction at the protein level of hemoglobin F. And you can see very significant induction by this knockdown. And we saw no obvious toxicities from the knockdown. This was sort of what would be predicted from Vijay Sankaran's and Stu's original paper. No alterations in progenitor numbers, no change in differentiation profiles, either myeloid or erythroid differentiation. But when we tried to do this, take these stem cells and put them into an animal, we repeatedly saw engraftment failure in the animal, which was unexplained at the time based on what was known about BCL11A. And so to sort of verify that what we were seeing was a result of the knockdown of BCL11A, we did this simple experiment where we transduced cells with a vector that knocked down BCL11A, and we competed it against a vector in which either it was a non-targeting vector or just contained the fluorochrome without any shRNA at all. And here you can see the result of this experiment where each of these triangles is a different mouse. And you can see week 4, week 8, week 12, the bone marrow at week 12 and the spleen, or at week 16, sorry. And the percent of engraftment of the cells from one versus the other vector transduced stem cells. And you can see in almost every case, the stem cell that wins in these animals is the non-targeting stem cell. So this is a real indication that targeting BCL11A has an untoward effect on the engraftment of the stem cell. So we thought, well, maybe this has to do with the fact that this is a mouse-specific area or effect. So we repeated these experiments with human CD34 cells, transplanting them into immunodeficient mice, and then analyzing engraftment at 12 weeks. And you can see, as expected, knockdown BCL11A inhibited the development of B cells in these animals, but also inhibited the development of myeloid stem cell derived monocytes and granulocytes. And so this told us that this was directly relevant to our approaches to translate this technology into humans. So the conclusion from multiple in vivo studies was that the knockdown of BCL11A appears to be associated with failed long-term engraftment of HSCs, and this was the first indication that BCL11A was not only important in B cells and not only important for repressing gamma induction, but it was important in stem cells themselves. So then we had to then solve two biological problems. One that I haven't really talked about is the expression of shRNAs at high levels can be toxic to cells due to non-specific events from the overexpression of the antisense RNA. And then we had to avoid the specific toxicities that I just reviewed with you, one in hematopoietic stem cells in particular, but also we expected the toxicity in B cells. So to do this, we went back to the drawing board and developed a new vector, which took advantage of the fact that these erythroid-specific cancers can be hooked up in a heterologous fashion with the beta promoter and then drive a lineage-specific expression only during erythroid development. And in this vector, we now, to do this, had to embed the shRNA in blue in a microRNA architecture in red. And the reason for this is because that allows this lineage-specific expression to occur. And so this is what we schematically, it looks like we've replaced the part of the microRNA shown in gray, the endogenous microRNA, with the BCL11A targeting shRNA. And this mimics endogenous microRNAs and leads to more physiologic or lower levels of expression with less non-specific toxicities. And then, as I mentioned, it allows regulated erythroid expression. And now, when we repeat this experiment where we're competing this new vector against the neutral vector, you can see indeed, when we look at engraftment, it's equal winners, if you will, between these stem cells derived from these two sets of transduced cells. So that told us that the new vector design was eliminating the toxicity in stem cell compartment. But if you think about it, it also brings up another question, which is the timing of the BCL11A knockdown during erythroid development dependent upon this transgene vector at the right time to de-repress gamma expression? And so here is how we looked at that. We used CD34 human cells, transduced them, and did erythroid differentiation in vitro. And here's a Western blot of BCL11A with the old vector, 3 of the shRNAs called SSFB. So it's a very high expression, ubiquitous promoter and enhancer, versus the LCR vectors with the same shRNAs. And you can see, in fact, we get excellent knockdown of the BCL11A during development. And more importantly, over here on the right, you can see, again, very good induction of gamma mRNA and very good induction of hemoglobin F in these 3. And you can compare that with what we saw in the same experiment with SSFB, and really at the same transduction rate, you can see as good as, maybe even a little bit better, induction of fetal hemoglobin. So then we asked the question, does this have an effect on the phenotype? Again, going back to a mouse model called the Berkeley mouse model of sickle cell disease. And we transduced the stem cells from a Berkeley sickle cell mouse and transplanted them into an irradiated congenic strain of mouse that didn't have sickle cell disease. And this transplant, in fact, led to, as you can see here in the controls, anemia and a very high reticulocyte count that's indicative of the fact that we've created sickle cell disease in this mouse. And when we knock down BCL11A using the vector that we intended to move into the clinic, you can see a very significant reduction in the hemolytic rate, not quite down to wild type levels, but certainly a significant reduction. And this is also shown here where we do flow analysis in the peripheral blood for nucleated red cells, which, as you know, also is an indication of erythroid stress. And we can reduce that number from 40% down to 5% with wild type animals showing around 2%. So again, just recapitulation that we've significantly reduced the hemolytic stress on these animals. And so we then wanted to move into a human trial. And just a minor point for the aficionados in the crowd, we decided to re-engineer our research vector into a clinical vector. And the basic idea here is to use a smaller enhancer sequences and to take out the fluorochrome. And we also used a synthetic poly-A site, but here's the exact same schmear as here. That's what we call this little shRNA, microRNA sequence. And so we asked the question in our preclinical work whether or not this GMP-produced vector, which we call BCH-BBB694, worked to induce fetal hemoglobin. And here you can see in 3 different patients color-coded with sickle cell disease, when we take their stem cells from bone marrow, transduce them, and then differentiate them in vitro, you can see in each case very good induction of fetal hemoglobin or mRNA. And what's really important then is that that's concomitant with a very significant reduction in the amount of sickle hemoglobin in these cells shown here on the right. So this led then to first in human study. It was a single center pilot and feasibility study because this had never been used in humans before. Originally, the study was designed to treat 7 patients in descending age orders. We've recently increased this pilot study to 15, and that's in preparation for a phase 2 multi-center study that I'll talk about in a second. And the inclusion criteria included the lack of a matched sibling donor and a severe phenotype in the usual severity scale that is used to indicate a person could be eligible for a transplant. So more than 2 episodes of ACS or more than 3 episodes of VOE or VOC in 2 years, recurrent priapism, red cell alloimmunization, and failure of the hydroxyurea to treat the patient. This shows you the design. We mobilized with plerixafor using a protocol developed here in Boston by Erica Ezrick and John Manis. And these patients have to have chronic transfusions for 3 months before the collection, and they have to stop hydroxyurea. We select CD34 cells, transduce them, cryopreserve them while we do release criteria, and then patients admitted to the hospital and given busulfan as a single conditioning agent and infused with gene-modified cells. So here are the recent published data from our New England Journal paper. It shows you the patient's age, their genotype, the reason that they're in the study with respect to clinical symptomology. Some of them were on chronic transfusions already, and the number of months that we've had follow-up. I'll just point out a couple things. This patient 01 had a great manufactured product, but subsequent to that developed some comorbidities that essentially eliminated her from the infusion part, and so she was never infused with the product. And then this patient 03 had moya, and so we prior to enrolling him, and actually at enrollment, we specified that because of this, he would have to go back on transfusions irregardless of the result that we got, because we felt it was too risky for him not to be transfused. In spite of that, he wanted to participate, so he went into the trial. But it makes his data a little bit more difficult to interpret. So again, for those who follow the field, we got very good stem cells for manufacturing from these patients using plerixafor. And the vector that we used was outstanding with respect to transducing the cells. You can see very high frequency on the right of transduced cells. So I can just give you the comparison. In our other gene therapy trials, these numbers are usually in the sort of 50 to 60% range, and these numbers are usually in the 1 to 2 range. So this is a very good vector. So this is a pilot phase 1 study, so the safety data are important. So pre-infusion, we had grade 3 AEs that were CVL related. So we had several patients that developed clots in their CVLs. We had one infection from line sepsis and a pneumothorax from insertion of the line. But there were no grade 3 AEs from the mobilization and collection procedures themselves, and there's been no adverse events associated with the medicinal product, and no clonal dominance. Now, we've looked at all of our patients now at all time points. We've been able to look at insertion site analysis, and there's no dominance at all in any of the patients. So these are the efficacy data which we've accumulated. And you can see that in these patients, we get excellent induction of hemoglobin Fs. So anywhere between about 20% up to 40%. And the amount of F per F cell is, you can see in general, above the 10 picograms that I referred to earlier in my talk. And more importantly, or as importantly, you can see over time, the percent of F cells in the peripheral blood is very high and stable. So somewhere between 60 and 80% in all the patients. So no patient has had a VOE since after gene therapy. There's been no acute chest or neurologic events. And except for the patient that we decided beforehand would go back on transfusions, no patients has required transfusions. And the one patient that was admitted to the study because of priapism required a hospitalization post-gene therapy. But over time, these priapism efforts resolved completely and have not recurred. And the patients are maintaining untransfused hemoglobins that are above 10. This patient 08, this was early in this patient's course, and this has now come up above 10. And there's been a reduction in the LDH and a reduction in the absolute retic count, although not to 0. So there is continued mild hemolysis in these patients. And this shows you the clinical events, and again, nothing post-gene therapy, except for this patient with priapism, where in the immediate period post-gene therapy, there continue to be some significant priapism. Then after 5 months, there was one episode, and then after 8 months, there's been no ED visits or hospitalization for priapism in this patient. And this patient's now almost 2 years post-gene therapy. So quite a significant effect on his quality of life. So, so far we've enrolled 10 patients. We've got effective GMP product developed for those 10 patients. 8 patients now, 9 patients have been infused. The last patient was infused, has recently been discharged from the hospital after a good engraftment. And we've now enrolled another patient that will basically end this trial, and we'll start our phase 2 trial. So this is a safe vector so far. It's extremely efficient in transducing stem cells. There's no adverse events related to the vector. The expression appears quite lineage specific. I didn't show you that data, and they're stable gene marking over time. And this smear targeting BCL11A results in very effective hemoglobin F induction with broadly distributed hemoglobin F and a high F per F cell and a significant attenuation of the sickling phenotype. So BCL11A, we think, is a very effective target, molecular target for sickle cell in humans. And this is important because additional approach to this are now being taken where we take advantage of the data that Dan Bauer generated as a postdoc with Stu, and then later confirmed on his own, where there is a small intronic sequence in BCL11A that contains, interestingly enough, enhancers that mediate the expression only in red cells and not in B cells or stem cells. And so this is really a nice target for gene editing. So either using zinc finger gene editing, that's how Sangamo is doing it, or using CRISPR-Cas9 as Dan is doing himself, and CRISPR Genetics is also doing in a clinical trial. This will then be a way that you can affect hemoglobin F induction using a non-viral approach, basically, to gene editing. And assuming that the efficiencies in large scale are consistent and feasible, the question will become then in the future, which of these methods of targeting BCL11A has better results, if any. So our future plans then are to complete this pilot study, as I mentioned. We have a long list of patients who want into the trial, and obviously a limited number of slots. And we've been recently funded by the NIH and by the California Institute of Regenerative Medicine to conduct a multi-institutional phase 2 trial. And that will include endpoints that are relevant to patients in a way that would allow us to use the data for FDA licensure in the future. Specifically, the endpoint is a complete reduction of VOEs to 0. So we're trying to make patients have no pain episodes after gene therapy treatment. We're also working on new vectors to even improve better, make better induction of fetal hemoglobin. Obviously, everybody is interested in reducing conditioning toxicity. So there's a large project here, as well as other places, in using immunoconjugates. And we're also developing in a project funded by the Gates Foundation, a way to target BCL11A in vivo. And this would allow us to expand this to countries and areas of the world where 30-day ICU stays in laminar flow rooms isn't feasible. And we're doing this in two ways. We're using nanoparticles in collaboration with the Koch Institute at MIT, and we're developing new viral vectors that can be used in vivo, and that's a collaboration with our own group, Christian Brindle at Dana-Farber, and Dave Skadden at the Massachusetts General Hospital. So if I come back to this cartogram, it's obvious to you that gene therapy can't be the answer to this huge burden of disease across the country. So Stu's probably told you he's working on an oral drug that could target BCL11A. And of course, in the end, another approach is prenatal diagnosis, and that's been very effective, as some of you likely know, for beta thalassemia, for instance, in Sardinia and parts of Greece. So this, in the future, is going to be a really important global health issue that needs to be addressed. So I'll stop there. I hope I've left time for some questions. This is a huge undertaking, as people can imagine, given the complexities of the therapy. We had funding from the National Institutes of Health, and I mentioned the Gates Foundation. This was done in the context of the gene therapy program here at Boston Children's, with a huge number of investigators, collaborators, but the primary person is Erica Esrick, who's a Hematology Oncology junior faculty member here. We use a special lab at Boston Children's developed to support these kind of trials called the Trans Lab. We have a GMP cell processing team at Dana-Farber Cancer Institute that we use, and we collaborate with several other units, the Brigham and Women's Hospital, the Experimental Therapeutics Unit at Boston Children's Mass General, and we've had great collaboration with our colleagues at Bluebird Bio. So I'll stop there, and see how one would like to answer questions.
Thank you, Professor William, for the excellent lecture and a deep insight into the gene therapy technology and demonstrating that BCL11A inhibition is an effective target for HbF induction and decreasing the disease severity in sickle cell patient. It was pleasure listening to you, sir. There are few questions which we will take it. And being a chair, I think I will ask you take the opportunity to ask you the first question. Sir, which therapeutic approach, according to you, is a better one? The one is gene editing or gene correction or reactivation of fetal hemoglobin. Why I'm asking this question is, sir, in gene correction, usually you get a disease-free survival or a chimeric cells you get. Whereas in reactivation of gamma globin gene, you make a use of a secondary modifiers to reduce the disease severity. So which you think will be a better therapeutic approach?
I think the good news is they both seem to be effective. So I think what will determine which is best has to do with a couple things. One is the durability of the effect from the efficacy side. One is the development of any adverse events. So each of those technologies has different potential adverse events. And then I think another driver of this will be cost. So if one can be developed that's substantially less expensive than the other, that in the end may be quite important for the broader application. So I think it's too early yet for us to know which of these technologies is going to be best. And I think the good thing for patients and for me as a sickle cell provider is that we have, for the first time in a number of years, several approaches that appear to be effective.
Okay, thank you. There are a few questions, sir. Two are related to thalassemia. They have asked, in thalassemia, why there is a recurrent bone marrow or blood transfusion required, though the HbF is very high, while in HbFH, they are asymptomatic.
Yeah, so this approach of inducing fetal hemoglobin is likely to be equally effective in thalassemia. We didn't test it in those patients, but we think it will be. And some of the other trials using gene editing are including thalassemia patients. The pathophysiology of thalassemia is quite different from sickle cell disease, because the main pathophysiology of thalassemia is ineffective erythropoiesis with premature apoptosis of red cell precursors in the bone marrow. And that leads to chronic expansion of the medullary cavity and extramedullary hematopoiesis. If you replace the expression from the adult beta locus with fetal hemoglobin, that should alleviate those pathophysiologic abnormalities.
Another question is related to the practical application. In lentiviral approach, how can you control the site of integration in human genome and copy number?
Oh, great question. So lentiviruses are relatively random, but they're not totally random, and you don't control where they go. And so one of the risks for any kind of insertion vector is that you create a mutation that leads to abnormal expression in the vicinity of the insertion. We've designed our vector so that it should not have any effect on a neighboring gene, because the enhancers are only active in red cell precursors, but it's still a risk, basically. And so that could be an advantage of gene editing, where you have a specific sequence that you're targeting. But the other side of that for gene editing is, of course, that there could be off-target genetic alterations from the approach. And that's what's going to need to have long-term follow-up, basically.
I think that's all what the questions we are having. Thanks a lot, sir, and hope your pilot study will be over and then we will get more patients into the clinical trials. Thank you, sir. Over to Shiva.
Great.
Thank you so much, sir. Thank you so much, Dr. Anita. Thank you. It was great, interesting talk. Thank you. Bye-bye.
Thank you. Bye.